Hello, my name is Christine Reichert. I am a student at Indiana State University in their Doctorate in Athletic Training program. And today I'm going to be talking about my ankle evaluation. So there's going to be three main things we're going to go over today. So first, what am I doing? Second, what am I missing? And third, how do I close the gap? So first off, what am I doing? My current evaluation method revolves around the HOPs: history, observation, palpation, and special tests. It's what I learned in undergrad. It's what I continue to do. It's just stuck with me throughout the years. So first comes HOPs, which stands for history. Who and what. So I always begin my evaluations asking for their name. My preceptor in undergrad used to quiz me on that, so I had to make sure that was the first question I ever asked. What, as in, what sport are they part of? When, where, and how was the injury. So when the injury happened, where the injury happened, body part and in the venue, and how it happened, so mechanism of injury. I usually end my history with past medical history, so I ask about whether they've had an injury on that side before, whether they have diabetes, sickle cell, asthma, or whether they've ever injured that body part before now. Then I move on to observation, which is exactly what it sounds like. I always begin with observing the side that it's on. Again, this preceptor that I had in undergrad would quiz me, and it was always a must. I had to tell her what side it was, and had to get into that habit. I look for obvious deformities, swelling, and discoloration. These can all give clues as to what's going on. P is for palpation. It's basically exactly what it sounds like. I go on to palpation, bony structures, soft tissue structures, and I make sure to palpate both for the ankle, both the ankle and the knee, and especially the foot. I move into passive range of motion, and then I go into strength. I usually rank them 5 out of 5, 4 out of 5, 3 out of 5. I don't do any of the pluses. Then we move on to special tests. So for the ankle specifically, I do anterior drawer, tailor tilt, the Kliger test, and the bump test. All right, so big question. Why am I doing this? Well, let's go back. History. Well, I'm always facing unfamiliar athletes. So knowing their name and what sport they are is the first thing I always ask. Secondly, it was ingrained in my mind as an undergraduate student that history is the most important part. I was taught that if you had an accurate history, you could diagnose the injury. You didn't even have to do anything else. So history should be thorough. Observation. Why I'm doing observation is, well, first of all, the side. The side is because you'll forget. You'll go to document and you'll think, was it right or was it left? Was it my right? Was it their right? You have to think back, and a lot of times it becomes extremely difficult to do that. Observation gives you the first visual impression of the injury. It gives you the first clue. You're not gathering any quantitative data, but it gives you the clues to what you're looking at, and it's an extremely important part of the evaluation. Thirdly, assessment, palpation, but it is the assessment. It gives clues. So again, to the injury and what we're dealing with. So passive range of motion and strength is to differentiate between muscle versus ligament. And then look at the function. Are they able to walk out of the athletic training room? Do they need a boot? Do they need crutches? Do they need ice? Etc. and so on. And finally, special tests. I do these because they are to rule out or rule in specific structures. So anterior drawer for the anterior talofibular ligament, the tailor tilt for the deltoid and the calcaneofibular ligament, the Kliger test for the deltoid ligament group, and bump and squeeze test to test out a fracture. All right, so what am I missing? I dove into a lot of literature this week and decided that I'm missing many steps, but I'm only going to talk about 5. And the first is permission and verbal cues. I realize that I don't exactly explain what I'm doing very well, and I also don't ask for permission. It should be noted that when you touch an athlete or a person without their permission, it's considered battery and against the law. It's important to explain what and why. A lot of the times I dive into an evaluation and quick to do the tailor tilt, but the athletes, all they know is that it hurts, and stopping and explaining to them can really not only aid in communication, but really, really increase trust and between you and the athlete. And finally, cultural considerations. It's very important that you know that a lot of cultures do not have the same expectations. Touching a woman in one culture is very offensive, whereas in the United States, it's not a big deal if I touch a female athlete. So you just have to take those into consideration and make sure not to offend anyone. Secondly, the Ottawa ankle rules. I have learned about this in undergrad. I should have been practicing this for years, but instead I decided to stick with less reliable bump and squeeze tests for reasons I cannot explain. Sensitivity of the Ottawa ankle rules is 96.4 to 99%. It's incredibly sensitive. It really only requires, 3 or 4 signs and symptoms. Now, I have learned the inability to bear weight and about the 6 centimeters on the fibula and tibia. However, I have never heard of the navicular or the proximal base of the 5th metatarsal, so that's something that I got to learn today doing my research, and I look forward to implementing that. Thirdly, circulation and sensation. I realize I don't even take that in consideration, and it's embarrassing. You got to be able to rule out compartment syndrome, occlusion of blood supply, and nerve damage, of course, because you got to think about fractures that even if they're small, they can really cause a lot of damage. And if you don't check that out immediately, it could be really detrimental to the patient. Thirdly, syndesmosis testing. Yeah, I often forget about the syndesmosis sprains, and it's because they're less common. But doing a simple dorsiflexion with external rotation or a cross-leg test is 2 easy ways that I can test the syndesmosis and not lag on my evaluation. So I need to stop focusing on just the lateral and medial structures of the ankle. And finally, bilateral testing. Once I did some reflection, I realized that I'm so quick to get a 5 out of 5 or get a positive talar tilt with pain, and I just forget to look at the anterior drawer and its laxity, or I forget to test the leg on the other side. And that's extremely important for both palpations, range of motion, strength, and special tests. All right, so how do I close the gap? It's a really good question. So doing so, we're going to go back to our evaluation method. So modified evaluation method. Now, it should be noted that both the modified evaluation and the original evaluation method, I'm documenting exactly the same. I use an online system, and there's no paper copies, which is very convenient. I usually log them in a SOAP note fashion, and then update the notes whenever I see the athlete, whether they just changed or not. I always make sure to mention that they did come in for rehab. So I do think that the documentation is the same for both. Now going into history, so what can I add? I can add ask permission. I think that's one of the big things that I need to get to be able to do, is saying, can I palpate you? Can I touch your ankle? Does this bother you? Etc. and so on. Secondly, observation. I think that that was okay. I like that I went over the sides and looked for the obvious clues in my evaluation. Thirdly, palpations. First of all, I need to test circulation sensation. I always check for a fracture first, but that really won't do me much good if I don't know if there's circulation or sensation. Palpations, going from palpations is to make sure to incorporate the Ottawa ankle rules. And to implement that, it's really going to get to know those rules and memorize those rules, and that's going to really close the gap. Because once I feel comfortable with a subject, I'll be able to implement it with ease. But right now, I need to be able to make sure to practice that, print it out, and add it to my archives, so that every time I have an ankle evaluation, or even a foot, I can make sure to apply these rules. And finally, palpation, range of motion, strength, and the Ottawa ankle rules all need to occur bilaterally. Lastly is the special tests. I need to add this as a syndesmosis testing, and again, this kind of goes along with the Ottawa ankle rules. As soon as I get comfortable in knowing the exact mechanism of injuries and the special tests that need to go on, that's going to be what's going to be closing the gap. But I think that needs to definitely occur, and I'll add special tests and take out the bump and the squeeze probably. But I don't think there's anything wrong with doing those. But of course, always test bilaterally, and that's one thing I definitely have to note. Thanks for listening, guys. I really delved into the research today, and I hope you learned something, because I know that I did. I have many more things to learn, but I am excited to improve. Thank you.